CAS is diagnosed by a speech language pathologist. We don't have like a certain age that the child has to be, but the child has to be able to imitate some sounds and syllables in order for us to kind of see what's going on with their mouth to be able to diagnose it. If they're not able to do that, we do have some characteristics that research has shown us that we can identify and suspect that maybe they have childhood apraxia of speech at an early age.
That is the characteristics that children with CAS frequently exhibit, but children with other types of speech sound disorders typically do not. Things like vowel distortions and prosodic deficits and consonant distortions, not just substitutions. Those kinds of things are often seen in children with childhood apraxia of speech. When a child can focus attention, watch your face, and attempt direct imitation, at least a few trials at a time, we can make the observations we need to make in order to say this child has characteristics of CAS.
Having a co-occurring disability can complicate a diagnosis because they have to have the some cognitive abilities to be able to attend and try to imitate what we're doing with our mouth, receptive language skills and that kind of thing. So sometimes it can be more difficult if there's co-occurring challenges going on.
There are some children who came to Mayo with the diagnosis of autism and CAS who did not have CAS, or no one would know whether or not they did because they didn't even have joint attention. They were echolalic. They could not even point to one of two items when asked, which do you want? So at that point, one can't know if they have a childhood apraxia of speech. And if they did, it wouldn't be what you would work on at that point. It would be joint attention. It would be making a choice, using, some kind of gestural communication. All children with autism do not have CAS, not even the majority of children. We do have some disorders where we have been able to determine that they have a higher risk of CAS and that we see it more often in these disorders than others. And they include galactosemia, velocardiofacial syndrome. Those are the two most genetic disorders where we see a high prevalence of CAS relative to others.
Apraxia of speech can be anywhere from a mild impact to a severe impact. And so the severe impact would be they have difficulty just saying simple words or sounds. And that can lead to a lot of frustration, anxiety, stress around it. They know what they want to say. That's the thing about children with apraxia is they know what they want to say and they understand everything being said to them. However, their ability to communicate their emotions, their needs, their wants, their, just to comment on things is limited, depending on the severity. We also know now from research that apraxia will have an impact on their reading abilities and literacy, and which will affect then their academics, and it can also affect their social abilities. And so we now have some data from children who are diagnosed with apraxia and now they're adults, and they talk about their the social anxiety and that may still be present as an adult or young adult. And so it can have some really lifelong impacts on the children. Treatment for apraxia of speech needs to be very intense. We recommend that children receive therapy anywhere from 3 to 4 or 5 times a week. That intensity is required, especially when they're first starting to learn to sequence those sounds. The therapy is very movement-based, so we're not trying to teach them how to make a sound and let's put our tongue in the right place and make a sound. That's not what our treatment is. The treatment needs to help them transition and go from one sound to another sound. So it's that movement that we do in speech that you and I don't think about. But for them, when they try to do that movement, their tongue gets in the wrong place, their lips are too far opened, or the motor plan that we have to have for speech is what they lack. And so our treatment teaches them those motor plans and how to put those sounds together to form words. And then we provide a lot of cueing and multisensory cueing to really help support the child. And then as the child gets more proficient, we fade those cues out as quickly as we can so that they're producing the motor pattern on their own. And then we also incorporate prosody and how to the natural flow of language and speech.
Dynamic temporal and tactile cueing, or DTTC, it's a treatment for children with particularly severe CAS. If they get frequent therapy, which we often recommend for the very severe children, like 3 to 4 times a week, for a period of time, then you can lessen that. And then pretty soon, even with the nonverbal kids, within a year, we're often starting to bring in a little phonologic therapy or therapy like rest to bring in more practice with prosody and naturalness. So we like to say no one treatment does all the job. As children's characteristics change, as their motor programming efficiency improves, then we want to bring in strategies for other systems as well. So DTTC has been very helpful in my practice to help these kids that are so severe start to develop these motor programs, be able to retrieve them and then habituate them so they don't have to think about it so hard. And that's the real key here, is to help them really establish more automaticity in their motor programming.
Prompt is a type of treatment where the therapist is actually doing tactile cues on the child's face to cue their tongue, their lips, their mouth, their voice. Maybe the sound goes through their nose as opposed to going through the mouth. It gives them those cues for each sound that they're saying. And so it's just another way to help those motor plans develop and gives them an actual tactile cue. It doesn't work for all kids because some children don't want you touching their face. They might be tactily defensive. And so they, you go to reach for their face and they're like, no. So sometimes children learn the cues and they cue themselves. As soon as you notice that the child's not able to get their communicative needs across, so they're having difficulty and they're having frustration around that, you want to try to give them an alternate way to communicate, whether it is having pictures for them to point to, or if it's sign language, or if it's a speech generating device that they can point to pictures on the device and it says the word or the sentence for them. And that choice of what you use is a choice made with the family and the SLP. And we know now from research that just because a child learns signs or has a communication device, that doesn't mean he's not going to work on the speech or that he's not going to learn speech, because some family members might think, well, if he learns sign, why is he going to talk? Well, we know that learning signs or this other way of communication does so much more to support their whole language development, and it actually encourages that speech and those motor plans for apraxia to come in.
I think more simplistic nonverbal communication aids for the children that are getting appropriate therapy and starting to make progress, that would be better for them. Now, certainly kids with severe dysarthria or other problems where either speech improvement will be very, very slow, or it's all compensatory and they will still have trouble with intelligibility, then those other systems are great. And they're built into their school life and home life and that kind of thing. But the children with even severe apraxia, they're not going to need an AAC device more than a year or two if they get the right kind of therapy and if it's frequent enough. It's up to who's ever seeing the child, along with the school personnel, to decide to what degree do they need a device and what kind of device to help in school.
When the child goes to school, they need to have their speech therapy, and it needs to be appropriate for apraxia by the therapist. But there's things that we can put into place in the classroom that's going to help the child as well. So if they have any kind of augmentative or alternative communication system, that system needs to be available throughout the whole school day. I also encourage it to be written in the IEP somewhere that the childhood apraxia of speech is a diagnosis, because it doesn't just affect speech. It does affect the child's academic and reading and literacy. Some things that can be put into place within the classroom are things like giving him extra time to respond orally, because sometimes he may know what he wants to say, but it might take him a few minutes, a little bit longer to get the word out. And being timed on tests or timed to do things is not good, because he does need that additional time, processing time. Giving him alternatives. So like when you're teaching reading, a lot of the times, the child's supposed to read aloud. Well, a child with apraxia may not be able to read aloud. Well, how do you test comprehension if you have them read something and you ask them questions? So having alternate ways, letting him point to pictures or giving him options. Did the boy in the story do this or did he do this? And and have pictures or a way to indicate that. I've heard of families having it written into their IEP that the child gets early release on certain days so that he can go to private speech therapy. And then the other thing is to not put pressure on the child to answer out loud or to talk. And teacher asks a question and kids raise their hand, don't call on the child with apraxia unless he does raise his hand. And so things like that are good things to put into the IEP.
When the child is first starting therapy, and I specialize in these very severe kids, so I don't have the parents do much of anything at first, except reinforce and play games at home where the child really focuses attention to the mom's or dad's face, because that's an important part of treatment early on. That visual cue is hugely important. If we're adding early sign for these nonverbal kids, then the parent has a huge role there. So, they're learning along with the child and developing ways where they speak, but also, of course, let the child initiate communication with the signs.
Once a child has mastered a word within the treatment session, and then we tell the parents, okay, here's what you need to practice. And so we'll give them, those words. And then, for a parent, some children are able to sit and practice with their parents, but a lot of kids don't want to do that. I do that in speech therapy. I don't want to have speech at home kind of thing. And so we try to encourage parents to really focus on how they can incorporate these words into their normal routines that they do. And typically we're working on very functional words. And so like a phrase like I do, that a child is mastered in therapy, then we tell parents, say, okay, you're going to give your child lots of opportunities to say, I do. And that's going to help those motor plans stick and generalize so that they can use them without trying to think about it. The other thing that I tell parents is to really support their child in having apraxia. Talking is really hard and it can be very frustrating. And so giving a child the space and the ability to have those feelings and to talk about them, and that it's okay to be mad because this is really hard. It's frustrating. And, everybody's got things that are hard to do, and people have things that are good, that are easy for them to do. What can you do that's easy? Oh, you can run, you can throw a ball, you can, race, whatever it is, kind of help them acknowledge and feed into those strengths that they have. And yes, talking is hard for you, and that's why you're working really hard. We're going to speech therapy, and we're getting better at it. You used to not be able to say this word, and let's hear you say it. Wow, you can say it great. So to help them, feel accomplishment.
The parent therapist partnership is huge. Parents really need to understand what we're trying to change. Parents really need, at whatever level that might be, they need to understand what is motor programming. They need to understand, why does my child have so much trouble talking? Why are you doing this and not that? Parents need to know that. And there's lots of ways to talk about that with them at whatever educational or language level they might be at. So it's just a plea for parent-clinician partnership.